I'm going to tell you about a rehabilitation study in people with progressive multiple sclerosis. We focused on cognitive deficits in this group. We did this because people with progressive MS, whether it's primary progressive or secondary progressive MS, have higher rates of cognitive difficulties, approaching 70 to 80%. Impaired cognition can affect a person's ability to work, maintain relationships, and undertake activities of daily living. So this is a very important clinical question. We did not know before undertaking our study whether people with more advanced MS could indeed show cognitive improvement. This is what we tried to answer. We only included individuals who had impairment, and we chose a particular cognitive index, processing speed. This is the quintessential or cardinal cognitive deficit in people with multiple sclerosis. If there are problems with processing speed, then you have challenges with multitasking, and it might also affect your working memory and your executive function. To get entry into our study, individuals had to have failed a test of processing speed. I worked with colleagues in the United Kingdom, the United States, Denmark, Italy, and Belgium. There were 11 centers involved in the study. We chose two interventions. One was cognitive rehabilitation, and the other was aerobic exercise. We hypothesized that by combining these two interventions, we would get a synergistic or combined effect. In other words, both interventions given together would be better than either intervention alone or sham or inactive interventions. We ended up with 4 treatment groups. One group got cognitive rehabilitation plus exercise. Another group got sham or inactive cognitive rehabilitation and inactive exercise. And there were 2 other groups who got either cognitive rehabilitation and sham exercise or exercise and sham cognitive rehabilitation. The test that we chose to measure processing speed was one called the Symbol Digit Modalities Test. This is a widely used cognitive test considered the standard measure for processing speed in people with MS. It takes about 90 seconds to complete. Individuals got treatment over 12 weeks for 2 sessions a week. So there were 24 sessions of treatment during our study. They were assessed at baseline and at 12 weeks. And we then waited another 6 months to repeat the assessment to see whether any benefits that had accrued were still present at 6 months. The outcome was as follows. We did not support our primary hypothesis. In other words, we failed to show that combined exercise and cognitive rehabilitation would have a beneficial effect or a more beneficial effect on improving processing speed. However, what we noted was that individuals from all 4 groups showed some significant improvement in processing speed. This reveals that our sham interventions were not inactive. Our results were significant because of the following. When there is a 4-point or more improvement on the Symbol Digit Modality Test, this is considered clinically significant with group data. If there is an improvement of 8 points or more on the same test, that's considered clinically significant for individual cognitive data. When we apply those thresholds to our study, we showed that 60% of our sample indeed had a 4-point or more improvement on this test at 12 weeks. And by 6 months, the percentage improved was 46%. When we look at the 8-point threshold, we showed that 37% of our sample was improved at 12 weeks. And by 6 months, the percentage was 26%. So overall, we were able to demonstrate a significant improvement in processing speed in a substantial number of individuals with more advanced progressive multiple sclerosis. We did not know this before the onset of our study. So although we did not meet our primary hypothesis, although we failed to show that the combined interventions brought about added benefit, we were able to demonstrate very clearly that in a number of people with progressive multiple sclerosis, you can indeed bring about an improvement in processing speed.